This is the port position for a laparoscopic splenectomy in a massive splenomegaly. So here we have put a primary port at the umbilicus because the spleen was extending up to the umbilicus. So to visualize the hilum, a port at the umbilicus is helpful. Here we are taking the lower pole of the spleen. We are detaching the splenocolic attachment, that is the splenocolic ligament, from the lower pole of the spleen. This will help to place a lateral port to lift the lower pole of the spleen. A lower lateral port is very helpful to lift the lower pole of the spleen. This will help to identify the structures in the splenic hilum and also the splenic artery and the splenic vein. Here the position of the patient is supine with left up and a shoulder back beneath the left shoulder. So here the lesser sac is entered by dividing the gastrocolic omentum. Once we enter the lesser sac, we can see the splenic artery and the splenic vein above the upper border of the pancreas. Here we prefer to use a ligature because ligature gives a bloodless field, and the curved tip of the ligature is very helpful to dissect like a harmonic. If the xiphisternum and the umbilical distance is more, as in this patient, you can always place another port midway between the xiphisternum and the umbilicus for a better visualization, as we did in this case. Some surgeons prefer a left up, that is a right lateral position for a massively enlarged spleen. But here we are using a supine position with a left up tilt. One has to be very careful and meticulous while taking down these short gastric vessels. If you hold the stomach, you may injure the stomach, which can cause post-operative peritonitis. And if you are in a haste, the vessels can retract and cause bleeding. And controlling bleeding in an obese patient like this can be difficult. In a splenectomy, the most important thing is to devascularize the spleen. This is done by ligating the splenic artery and the splenic vein and dividing the short gastric vessels. So once you divide the short gastric vessels and the splenic artery, the blood supply to the spleen is cut off, and you can carefully then divide the splenic vein and then do the hilum. You can see that the patient has early cirrhosis and the splenic vein is very much dilated. It's a huge splenic vein. Even the splenic artery is very much dilated and very tortuous. During the preoperative evaluation, endoscopy did not show any varices in this patient. Here you can see a dilated splenic vein. The camera port should be above the level of the umbilicus, that is supraumbilical camera port. In huge spleen like this, a lower port is recommended. A position that is right lateral and a left up position is recommended. In this patient, we are using a supine position with left upper tilt. Here the splenic vein is being dissected and you can see a preserved plane around the splenic vein. You can see the pancreas there. One should be very careful not to injure the pancreas. The splenic vessels have a relatively constant position at the upper border of the pancreas. So always dissect the splenic vessels at the upper border of the pancreas. You can see that there is bleeding from a capsular tear. The lower pole of the spleen has a capsular tear. Due to the weight of the spleen and retraction, the capsule has torn and it starts bleeding. So bleeding will obscure the view. So it is important to have the bleeding arrested. One can use a gauze like this and compress. You can ligate the lower polar vessels. You can also use a bipolar diathermy to arrest the bleed. Ligating or dividing these lower polar vessels will decrease the vascularity to an extent. It will decrease the bleed from the capsular tear, and it also helps in retracting. A proper retraction is possible when you take these lower polar vessels. One can also use an endo-GI stapler with a vascular reload to control the hilum. So if you can identify the splenic artery and vein and see the pancreas and separate the pancreas, and if the hilum is clear, you can always use a endo-GI stapler with a vascular reload. With this you can see that the bleeding has decreased and the retraction is much better now, and you can proceed with the splenic artery dissection. Here the main splenic artery is not clear, but you can see the branches, the large tortuous branches of the splenic artery, and we are going to dissect and ligate these two branches. You can ligate and leave them like that without dividing the splenic artery and vein, and you can just take the hilum. So here we have clipped the splenic artery and splenic vein with the intent of dividing them, but we have not divided. A vessel loop is very helpful in handling the splenic artery here. So we are using a vessel loop to dissect the splenic artery, and you can avoid handling the splenic artery if you use the vessel loop. So trauma to the splenic artery will decrease if you are using the vessel loop. The splenic artery branches are being clipped with a humalock. The idea was to divide the splenic artery, but we have not divided here. The second branch of the splenic artery is being dissected. 5 mm right angle forceps is very helpful in dissecting the splenic artery and the splenic vein. Here we are using a heavier vessel loop to facilitate dissection of the splenic artery and ligation. Once you clip and ligate the splenic artery, the spleen is devascularized. Here we have used 4 clips with the intent of dividing the splenic artery branches, but we have not divided the splenic artery. Using the gauze will keep the field dry, and especially the small capillary ooze is better controlled with the gauze. Here you can see that the splenic vein is very much dilated, and you are dissecting the splenic vein now. So there will be a lot of tributaries from the pancreas to the splenic vein. So handling the splenic vein too much can cause bleeding from the splenic vein due to small tears, and this can obscure the field. So one has to avoid handling the splenic vein too much, be gentle in dissection. One has to ligate and divide the small tributaries during the dissection of the splenic vein. This will avoid tearing and retraction of these tributaries. One such tributary being clipped and divided. This is the upper border of the pancreas. Be careful not to injure the pancreas. A right angle instrument is a very useful dissecting tool. As the splenic vein is very much dilated, here it is difficult to apply a clip. Either you need to ligate the clip and decrease the size of the splenic vein and then clip, or you can use a stapler, an endo-GIS stapler with a vascular load you can use and then divide the splenic vein. A massive spleen like this poses several challenges for a laparoscopic procedure, especially if there is portal hypertension. Here the splenic vein is ligated with a silk, number 1 silk. This will decrease the size of the splenic vein and then you can clip the splenic vein. As mentioned before, you can also use a endo-GIS stapler with a vascular reload to divide the splenic vein. Here we are using a hemlock to clip the splenic vein. Spleen is now completely devascularized, and now you can take care of the hilum. Here you can use a ligature to divide the hilum or clip every branch at the hilum and then divide the hilum. The problems you encounter while doing this is bleeding from the splenic vein branches. Though the spleen is devascularized, the blood from the spleen will pool here if you open the splenic vein branches here. That is why we are clipping the splenic vein branches. The second important thing is here you will see the tail of the pancreas. The tail of the pancreas is very close to the hilum. So if you are not careful, you will injure the tail of the pancreas and cause pancreatitis and pancreatic fistula. So you can see some bleeding there due to opening of the splenic vein branches. The blood from the spleen is started pooling here. So need not panic. It is the blood from the spleen. So it is not from the splenic artery or the splenic vein. So here you can just hold with the help of a forceps and use a suction to suck out all the blood, and then identify where the vein is bleeding and then clip it. Once you do this, the bleeding will stop, and then you can proceed with further dissection and ligation of the hilum. This large vein cannot be clipped here, so this will be ligated and then clipped. While doing this, it's very important not to injure the tail of the pancreas, and one has to carefully look for and identify the tail of the pancreas. If you injure the tail of the pancreas here, you will have either a pancreatic fistula or pancreatitis. You can see the tail of the pancreas here. The splenic hilum is completely divided now, and the last part will be the division of the splenorenal ligament. Because the spleen is a very heavy and large spleen here, it will be difficult to lift the spleen. So left lateral position is very helpful. By lifting the spleen with a lower pole retraction upwards, one can easily divide the splenorenal ligament. Here the diaphragmatic attachments of the colon are being divided. So as mentioned before, doing a lap splenectomy in a large spleen is ergonomically very challenging, and it's very evident here. Sometimes due to chronic adhesions, taking down these attachments may be difficult. After the division of the splenorenal ligament, the specimen was extracted completely without pulverization. A small left subcostal incision was made to deliver the specimen out. Another 10 mm supraumbilical midline camera port was placed to change the camera position. Taking the splenorenal ligament can be a very difficult part of the surgery. Here the left kidney is exposed.